I'm super happy to have Chuck Mayo with us. He's a professor and director of Rad-Onc Informatics and Analytics at University of Michigan. I've known Chuck for a while. We've interacted and crossed paths in several times. So I'm super happy that he's here. He's going to talk to us about how the treatment planning of patients that are receiving irradiation at the University of Michigan happens, and specifically the physics special consultation process. So Dr. Mayo, I just posted his biography here. He's got an up-to-date picture, but graduated from UMass in 1990 and has been very active in our, very clinical in our field for since he started. So I'll leave the floor to you. Chuck, thank you very much. And I'd like to also thank Maria Popovic, of course, for organizing this as well. So I'm going to stop share, and I guess it's up to you now. See if you can share.
Okay, let's see if I can. Slideshow from beginning, and then Zoom. Can I share this one? Can you all see? Everybody can see? Okay, good. And if you want to jump in at any point and ask a question, go right ahead. I think that's the best part of this is an exchange. I know a lot about what we do, but I'm really curious about what you do and how all of this interfaces. So here we go. So this is what we'll be talking about, go over our processes here and what has become routine, some of the things we've learned in our processes, where some of the gotchas are, and at the end, just highlighting some of the things that I think really would be valuable as a field for us to take as next steps. So this is a team sport to do this. So on the left are physicians that routinely are doing re-irradiation with SBRT and needing to get information from us in physics. On the right are the set of physicists that handle most of these SMPC requests. We all work together as a team in the various parts of figuring out what our processes will be, what kinds of standardizations we'll use. So everybody in this group is aware of all these parts, and we try to function together. Okay. So the ramp up is really interesting. So one way of reflecting that is I just took a look at publications. Publications are usually a reasonable reflection of what's happening in the clinic, or at least the volume and the time scale. And so if you're just looking at re-irradiation, you can see that, this is 2000, 2020. Re-irradiation has been a topic for quite a while. Patients get treated, they come back. And there wasn't a whole lot changing for quite a while. And then in 2000, it started to gradually ramp up, and you can see that we're getting this, much more exponential ramp up, which we all feel in our own clinics. As if you look back 5 years ago and say, how often was I spending a lot of time on re-irradiation compared to today? I imagine for you, like for us, it's vastly different. I'm working a lot on SMPCs all the time. And I think that's largely driven by what's happened with SBRT in that timeline. So, SBRT started kicking in around 2005. By 2010, you can see this ramp up starting to come. So there's a bit of a 5-year lag time with SBRT. And now this is starting to just sort of roll over and taper out for things that are just SBRT, and re-irradiation has just become commonplace. We all do this. But the re-irradiation is the new thing that all of us are dealing with in our own clinics. In our clinic, in the beginning, there was disorder. So there wasn't a systematic approach. It was a new problem. Suddenly there's a ramp up of patients coming through the door, and every physician in their own practice is figuring out, how do we deal with this? They're asking different questions of physics for what pieces of information will be helpful to them in their decision frameworks. We're operating with different approaches to how to answer those questions. One of the benefits of not being too big, as you were pointing out, Bill, that we're similar size, it's big enough that you're seeing quite a lot, but people can get together and say, what can we consolidate our approaches? It's not so large that that's not possible. And so we began doing that with combining that team of physics and physicians, trying to sort out what to do. For us, we had a huge advantage in a piece of software technology. So the script that we run inside of Eclipse called Dvh Analysis was created years before by Martha Matuzak and Chunik Lee and Carlos Anderson. It was created just for general calculations of biological doses. Michigan has been very interested in modeling and biological dose for many, many years. And so this came up as wanting a tool that gave a way to be able to do that. That tool, the way it works is it will look, if we've got, it will convert the dose distribution that's physical dose into EQD2 dose on a pixel by pixel basis, and with an assigned alpha beta for the structures in it, and then let it recreate the DVHs and give you EQD2 doses. For example, over here, we're looking at a liver dose, and we're wanting to calculate a mean dose, but using the alpha beta, so we can put in the alpha beta to use, and the other metrics, and so it's going to make that conversion for that dose field with that alpha beta, and then calculate it for that structure. So it was a really nice piece of software. When TG263 came out, that was a real opportunity to leverage the standardization of the DVH nomenclature. Because sometimes you want to know about specifically about volume or percent volume or the part. Increasingly, as here, liver, we want to know about the cold part. So the part that got a certain dose or less. Conventional metrics are a certain dose or more. But when we're looking at sparing, a lot of times we want to know that other piece. And so that standardization in how we write those down meant that in the program, they could then say, okay, if you see the string that looks like this, then this is what it means in the calculation. So it gave us a way to get the complete set for anything we could want, and the program can handle it and give us the results. And so we'll do that routinely here. And so in this example, you'll see we've got a plan, we've got a discounted plan, and then a plan without the discount. We're going to talk a lot more about that, so don't worry. You'll see all those details ad nauseum. And then in this case, we're looking at the volume that got EQD2 20 gray or less in cc's, right? So we can say 700 in the original plan, 717 cc's got less than 20 EQD2 dose. And if I add them up, then smaller volumes, because more of it got irradiated with the accumulation. So we use this routinely, and this has really been at the core of our process, leveraging this software. It can work with individual plans or plan sums, and you can see we can also calculate NTCPs. That also factors into some of our analyses here as well. So we had the tools to in the background and the culture that already had a lot of strong focus on EQD2 doses for biological conversions. And so that then set the platform. We want to combine things. We have a way of doing it. You've got an original plan that's done in 25 fractions, and now you're going to do an SBRT. in 5 fractions, and maybe 5 years later, you're going to do another one in 3 fractions. So how to figure out how to talk about all of that together. But one of the problems that we then face is, okay, you've got all this, great, but what are the dose limits going to be? And everybody is trying to figure that out in their own practice. And there are concepts that come in beyond the limits is, well, there's going to be some repair. I treated this patient 10 years ago, or this patient was treated 5 years ago, or they were treated 3 months ago. There's probably been some repair of the tissue in the meantime, so that dose that they gave, they've to the normal tissues, they've recovered from. But how do we, and so that suggests you could discount that dose, that maybe they got 50 gray, but it was 10 years ago, so you could treat it biologically like they only got 25 gray. So what should that discount be? And unfortunately, there's just a lack of information in the literature to be able to do that. So I think the situation I think we all find ourselves in reminds me a lot of the Amami paper from 1991. And so there, they pulled together a group of physicians. I don't know do you all remember the Amami paper? If you do, okay, very good. Right, and so at MGH, they pulled together a group of physicians into a room basically saying, what do you think we should do? You guys are smart, but give me your best WAG on what we should do that we can find a consensus around. So similarly with our physicians, they're reviewing the literature, they're treating the patients, they got a good sense of what they can probably do. And so defined here what our EQD2 limits should be, and then developed a table for how much to discount the dose by. And this has, of course, iterated. So this, you're going to see all current values that we have, and they have changed over the last few years. They've changed in the direction of realizing we can probably deliver more dose than we thought we could. So they haven't, so far, we haven't run into problems that's required us to go in the other direction. And one of the things I would say here that we've pushed really hard for, and you'll understand as I go through our process a little later, was reducing complexity. So we early on had versions where for different time frames, they had really different numbers in the discount for different structures for how much to discount it by. So maybe instead of 10%, they say 15 for this structure or 30 for that structure. But when you try to construct the plan sums to reflect the weighting, all of a sudden it becomes extremely complex. And so pushing back to say, unless you're really sure there's a biological difference you can see between 10 for one structure and 15 for another, can you just pick one that we use for both of them in that time frame? So this is still a process where we're iterating here in each of these. And in particular, we struggle a lot with this last column because we'll see patients that are coming in greater than 3 years. And you might suspect it should be even more discount. And so sometimes that will be customized. Any questions so far? Okay. And so with the tools, then we want to be able to report the results. So this is an example of what we'll see in the final report that helps us get through this review in chart rounds really well. So we've used the Dvh analysis. We've constructed the physical and the biological dose for the plan, for all the plans together, and then the plans with the discounts. We highlight, did we pass or not pass the limit? So it just makes it easy to do you're looking for green if you can see it, or yellow if you didn't pass, to let you know. Then we also work to create images that very succinctly get to the point of where the high doses are. So, a picture is worth 1,000 words. And when you're trying to go through chart rounds, long narrative text that goes through every possible thing that you did and demonstrates your high testosterone of being a really, detailed person is not helpful. because they're trying to get to the bottom line. Have we got a problem? Have we not got a problem? If we do have a problem, where is the problem? Where in the body is the problem? And so we use these images to try to succinctly show what's going on. So in this example, we can see in the current plan, in this liver, I've got two areas that are being treated. In the summed plan, the part where the overlap is here. And so visually, well, it's not right up against the spine. The duodenum may be an issue. So maybe I want to go look at the duodenum. Oh, okay, well, my duodenum dose is okay. So we try to couple those things together in our reports. Here's an example in the brain. So you can see that we have, we're retreating the same area. The doses are very different. Color wash is just awesome versus isodose lines for these displays, because it means, I'll use this to tweak to what I'm trying to talk about in the dose. So I know the brainstem is the main issue here. So I can, adjust this slider until I can show where it's touching, and do the same thing here on the discounted. So it becomes possible to see where these dose levels are. Occasionally, it's advantageous to actually rotate this plane. So if I wanted to see something happening along the track of the optic nerve, then I can rotate this plane, and over here, that would put my sagittal right along. I could follow the optic nerve, and that would be a way of highlighting it. So putting this time and effort into the visual display and what you're going to put into the report, that really helps us a lot for quickly getting to the key points you're trying to make in the final report. So this example in the brain, you can see how we're looking at all of these structures, highlighting them green. Increasingly, we're finding for SRS, they're really interested in the volume of brain that got 100 EQD2 or less in cc's. And so we'll also make structures that carve out the PTV, because obviously the part that's in the PTV is going to get a high dose. What you're really trying to figure out is the part of the brain that wasn't in that target area. So we'll use that too here in the brain. So how are we, incorporating these discount factors? So we take advantage in Eclipse of the plan sums and the weighting factors. So in this case, if we've decided for a set of organs, I can use a 50% discount for the prior irradiation. Then when I make a plan sum, I'll apply a 50% weight for that plan. And if it's going to, then full dose on this one. But you can quickly see how it can get very complicated if in that matrix, I've got different weighting factors changing by the structure. What do I do for the small bowel versus what do I do for the spinal cord, or for differing time ranges, because I had some plans that were treated 5 years ago, I had some plans that were treated 3 months ago. And so, when the questions you have to answer spans those range, we end up creating multiple plan sums with multiple weighting factors so that we can have that result to display. So that doesn't, fortunately, in practice, we don't usually end up needing more than 2. It used to be more complicated till we pushed, back here, when we pushed to try to get people to unify these time ranges, we could sometimes have 5, but with this, it's usually only a couple, and we haven't lost anything in terms of our ability to protect our patients and inform the physicians of the information they're looking for. We don't always achieve the results that we want. So in this case, this is a case where the tumor was right up against the chest wall. So it's highlighted yellow. We didn't make the 100 EQD2 limit that had been set for the chest wall. So our plans will not always be all green. The point of this is to be sure that we can highlight, we can give people as complete information as possible. If there are structures that were not checked off by the physician, I want to know about this one, I want to know about this one, I want to know about this one, but the physicist, as they're doing it, says, well, you probably ought to pay attention to the aorta, or you ought to pay attention to this other structure in here. We'll put it in, so it's there for information, but we won't color it, right? Because they haven't set limits, so we're not telling them, you haven't made your own limits, but you're giving them complete information so they can figure it out. And with this approach, we're also, we're routinely giving them the physical and the biologically corrected dose. And we show them the results with the dose discount and without the dose discount. I'll tell you, some of the physicians really would rather not have that column without the dose discounts there, because sometimes the numbers are high. But as you've done modeling, so the LQ model does not give you, it is an awesome starting point, but it may not be the only, give you the best answer or the most complete answer. And in particular, if you're finding yourself in scenarios, which we occasionally will do, where the EQD2 is really low, but because there's been lots of plans, the physical dose is really high. And you might start wondering, how much do I trust that model when, maybe this is 200 and that's 100? Because that can happen sometimes depending on the particular configuration of the dose with respect to the organs in some cases. And so at least in this case, you've had a flag. It's also important because when we look through the literature, most places are not doing discounts. And if they are, they're probably not using the same numbers we're using. And most are not doing EQD2 doses. Most are doing physical doses. So at least we have a way of connecting back. So if I'm trying to go into the literature, this corner up here is probably what I'm mostly going to see. And so that gives us a chance to at least connect there as well. And so when we started out, we just gave these before or after they were done. So the physician and the planner would do their work. They come back and say, what does it look like? Are we making our limits? And we'd say yes or no. And increasingly, I start saying, can we add a section in this document where you're showing us what you think should be our target? Can you give us something to aim for? And it can get really complicated. So here's one. We've got a liver. So we're on round 6 on the liver with this set of constraints that we're looking for. And so we'll go in, and for each of these, the physicist doing the SMPC will do the registration and adjust it with biasing to align toward the particular organs at risk. So for example, in the liver, spine may be checked off, but the real issue could be the duodenum. And so you want to make sure that we're doing a rigid registration here, that we're biasing it toward the dose on the duodenum. That's the main risk factor, not so important on the spine. I will say we have looked at deformable options and decided we didn't think any of them were good enough to be used reliably. So we'd rather accept the devil we know in the rigid registration rather than risk having problems that look hidden in a deformable registration. At least that's where we are for now. And so the physicist will do this and they will review it. Later on, the physician comes along and approves it. And then we'll look through each of these and make sure, we thought we were going to deliver 3 fractions, but did we actually deliver 3 fractions? If we didn't, you remember that when we made our plan sum with the weighting factor, then we would include that fact in the weighting factor. So suppose we got a plan where they thought they were going to do 30 fractions, but they only did 15 fractions. And it was 5 years ago, so we were doing a discount factor of 50%. So Well, we only delivered half the dose, so that's 0.5, and our discount factor is 0.5. So in the weight, we would put 0.25. So we're trying, when we make that plan sum, we're accounting both for the discount as well as for did we actually deliver all the dose that that plan has in it. Does that make sense? Okay. And so we would carry out the provisional plan. We encourage the dosimetrists, even if it's not going to be their final plan, just put in something that looks reasonable, has some dose, because we can learn so much from these images and these estimations of where you're at risk, where's the tiger territory for the things that we may be exceeding limits. It shows up all the time. This is an example, in fact, where when the physician put in the SMPC, they hadn't checked off heart. But when I went in and looked at it, I say, wait a minute, you're worried about these things, but the one that's really going to get you in trouble is the heart. And so having that 3D dose display gave us a chance to actually highlight, here's your overlap, but with some of these courses, but this is the one that's really going to be the big issue, and we can quantify that and advise them what to do. Here, you want to drop that down. This is over our limits. So we say, you should go back. We've got to fix this so that it's not going to be that high. So how do we do that? This is another tool. This one was one that I made in response to what I was doing with SMPCs. So it's an EQD2 grade balance sheet. So you're all familiar with making conversions in EQD2, but I find that there are lots of scenarios where I need to do slightly different things with it. Sometimes I just want to add up all the doses. Sometimes I want to say, well, I've given this much, how much is left? And I'll know how much is left in EQD2, but I say, well, I need it in physical dose because my dosimetrist is going to deal with physical dose. So in this case, this is a calculation where I can assign a weighting factor. It's usually 0 to 1. Some factor. So in this case, I'm going to do a subtraction. So I'm going to subtract this from that. If I want to add them up, so I'm looking at my total doses, and I just make it a 1. So I can do that. And so I can have as many as I need through here. And then they all get tallied up for the EQD2. And then I'll often want to know, well, how do I convert that into physical dose? And so I just put in, well, for how many fractions we need. And that tells me how much physical dose is there. So in this case, I'm using it to say, my limit from that spreadsheet, from that matrix is 60 gray. And since it's EQD2, then I'm just going to figure out how many fractions does that correspond to, so that I have the same number. Then I know how much dose was delivered. In this case, because I had multiple fractions that were delivered at multiple times, I went back to that spreadsheet and said, what's the EQD2 number that I'm going to plug in there? And so then I could just do it, make that divide by 2, so I know, I could just calculate the n that gives me the same EQD2. Now I can say, well, here's how much is left that you can do. And we know when we do this that it's the 3D is going to be the final decision. Did we make it or not? But that point dose calculation gives them something to point at. So here's an example where we're doing a patient in pelvis that's been irradiated. They've had several, conventional, SBRT, SRS like. They want to give 16 gray and 1. They're looking at overlap, and I need to figure out, what am I going to recommend for them for dose limits. So again, we go through and carefully bias each of these toward the specific organs. Just as an aside, sometimes you may discover, I got a target down here, and I got another target down there. And down here, the issue is the cauda, and up there, the issue is going to be bowel. And one registration won't work for both. In that case, I got to do multiple registrations and multiple calculations. Fortunately, that doesn't happen all that often, but when it does, if we need to, then we'll just will bite the bullet and make those multiple registrations and calculations in order to get the estimates. So in this case, when I pulled all that information together, I could see that the prior treatments did have an overlap here that was close to the cauda, but the target they're treating is down here in the pelvis. So these visual displays are just awesome for quickly answering the question, what are the risks of overlap? It's very clear that the things I'm going to be worrying about here are the sacral plexus. Not so much the cauda, it's far away, and probably not the bowel. Whereas if I just looked at numbers, it would be very hard to convey that information. So the images are really fantastic for being able to be clear about where the issues are. So in this case, then I did this calculation with our preliminary plan. I got my dose numbers. I could feed them in. So here we're looking at the thecal sac and our limit. And then I can give dosimetry suggestions. If you're going to deliver, you want to do that 16 gray in 1, then try to limit the doses to these values. And I'll use that color wash where I can to see, to look specifically spatially where is it up against that limit. And so then in the final plan, remember the point doses are just to help you get to here's the ballpark. Those point dose calculations can't account for the spatial distribution. It's hot over here in this plan and hot over there in that plan, but when I put them together, what's it going to look like? Your DICOM and your combined plan gives you the best tools for being able to answer that question. You do as well as you can with a hand calc, but this is really the better way to do it. And so when we come back in the final plan, this is then how we're making that evaluation. And you can see how this one got more complex because we've got bowel. It's got a different discount factor from the cauda and the sacral plexus. So I had to make a couple more plan sums here to be able to check whether we met it. And so they're all green, and I can give them a display that shows, here's where our target is, here's the overlap in the prior fields. Our images are very straightforward for what the interpretation is. Here's an example in the spine. So this is the final part. This is the pre-planning part. Sometimes, we'll use comments. We try to be succinct and direct and define exactly what we're doing, but here the physicist prior to planning was giving some detail over what some of the issues were she was wrestling with. And in the end, it comes to this final report where we can see, yes, we're meeting our constraints with respect to that matrix defined up above, and have the image to see, here's what our current plan is, and then this is the specific area, and you can see it's going to involve the sacral plexus or the brachial plexus, so that's the part here. You come up to those numbers, you could sanity check the image against the display. What do we do when there's no DICOM RT available from the outside institution? That happens more than I could wish. So we'll estimate the dose based on the paper and PDF record and the planning experience. So here's an example where a patient was treated outside. Here's a 4-field box that was used in the pelvis. We don't have the DICOM RT. We sort of know from the bony anatomy what was treated. Here's the current plan. So I know from this image, I can go back and forth and say, well, I can see where the issues are going to be. So combining those two lets us know where to focus our intention in figuring out the point dose calculations. Hopefully they've provided information, Dvh information, so I can at least pull out doses that they had and maybe on some of the structures. They don't always do that for all the structures, and so sometimes you have to put on your planner hat and know what the likely doses are to use in that calculation. If they have only had 3D, so in this case, suppose this was all they had, then what I would have done is gone back in and I would have recreated this 3D plan onto this image set. So I'll have to make the MLCs and, you know, do the whole thing. But then at least I've got a 3D dose distribution that's a mock-up of what they've done. And that lets us get more spatial information in so we could actually go back to using the plan sum. And everybody really likes that when they can do that. The physicians are happy with it. In this case, it's not possible because they had a tomotherapy boost. So I don't really have a way of mocking that up in a way that I have any confidence about. So I'm really going to be limited to just point dose evaluations in that case. And so then we give them an example. You know, we'll highlight what we think their limits should be, and at the end we'll ask, did they meet those limits? So here's any questions so far? Does this all make sense, what we're doing? Okay. So here's what our process flow is like. So the physician will know up front if they're going to need an SMPC. So we're going to be retreating an area. So they will drop a task in our care path and fill out that document that's that report. They need to specify what plans they've had before. Is it from an outside institution? They need to tell us, importantly, how many fractions they're planning to deliver, because I can't give them any calculations if I don't know, is it going to be a 5 fraction plan, a 28 fraction plan, right? It all depends on that. It's interesting when people aren't doing these calculations, they tend to think it's about the dose that you're planning to prescribe, not realizing it, you know, the dose you're planning to prescribe matters a lot, hardly matters at all. What matters is how many fractions it took to get that dose in there. The patient is simulated and the physician contours. Dosimetry does contouring, so that's blue, that's just our normal process. The physician will have, at this point, usually there's some paperwork to request the DICOM-RT be sent, and it has to be signed off by the physician or an authorized delegate to say to this outside institution, hey, can you please send me these DICOM records? So they'll get that done up front, and then dosimetry, we have in particular one dosimetrist who does a lot of these for us, will import those external DICOM RTs into Eclipse so that when physics goes in, they're already there. And the plans have been there. There were some iterations with getting them used to, you know, when you do the import, it may import with one saying that the plan was delivered in 1 fraction, when in fact, you know, it was delivered in 28. So, you know, training for how they fix that so that it reflects the actual 28. So when we come to our biologically corrected dose calculations, it'll make sense. But we really rely heavily on the dosimetrists. We'd be in the soup without them for what they're doing, all the work they do to pull these in. Physics will go in, as I said, and, you know, as part of this, reviewing the registrations. Usually dosimetry has done the registration up front, but I find about half the time I'm making some changes that I think are important for being able to calculate the numbers. And so we'll go back in, you know, just go through and make any tweaks or adjustments we need. After dosimetry is done with their part, this becomes available to the SMPC physicist, and the physicist picking it up will do that pre-plan evaluation. So they're trying to give dosimetry some numbers that they can use as they're starting in their iteration to plan. Sometimes that's enough and they just go straight through. Sometimes, excuse me, there are multiple iterations. In particular, there are multiple iterations when there are really steep dose gradients that are created by this combination of plans. And in our point dose calculation, really can't account for that. So we have to go through, run the plan, do the Dvh analysis, say, well, you know, you can nudge this up here and up there. And so we iterate until we converge on something that works. And then, so there'll be iterative dialogue, usually by email or Skype these days. Used to be a lot more in person, which I thought went better, but this is okay. Then the physicist will create the final SMPC plan. When that's done, we just go through the rest of our routine process. Physician's reviewing the plan, dosimetrist sets the plan to planning approved, physicist performs the plan check, we get IMRT QA, we get physicist doing the final IMRT plan check after the QA and approving the plan, and it moves to treatment. And then at chart rounds, we pull this SMPC up. And the way that report is constructed is really important. In chart rounds, they want to move through it fast. So you get at most a few seconds. Usually their physicist will be pulling up the SMPCs, and the question will come, is there any issue here? So it's really important to be able to converge quickly on, whether we pass, all the greens, whether we failed, all the yellows, where was it, where's the issue, what were the considerations that the physician made there. And we'll use the care path to be able to reflect that. So here's an example of where the medical physics consult is showing up. We don't see many complications. And when you look through the literature, I'm not going to do an exhaustive literature review, but just highlighting in general what we're seeing. But that's a pretty typical scenario. So we worry a lot about it. We build our process to be very robust to inform us. We do see them, but it's just, it's not frequent enough to be able to know for sure where the thresholds are. So in this case, when they're looking at spine injury, discovering that diabetes actually matters. Myelopathy is relatively low in incidence, but if they look at all the factors that are affecting their toxicities, they can see a really big difference over here for the patients with diabetes versus without, compared to time between radiation courses or amount of overlap or median doses. Another example here, looking at spine metastases, a multi-institutional review, just pointing out, myelopathy in the spine SBRT around 1.2%. So it's not that high in that combined experience. In the brain, these Kazim and Soon are highlighting, toxicity not uniformly reported when they're going through these reviews. This is a consistent problem that we have. The main thing people are interested in are toxicities, because that's what you're trying to avoid. But when we don't have many events or they are underreported, it's very difficult to figure out where the risks are. In lung, here are some couple of articles looking at lung cancer and toxicities. This group was 250 patients. This was only 30, but showing similar results in this case of grade 1 and 2, about 40%, but hardly no grade 3. Down here in this Red Journal article, around 55% of grade 1 or 2, dyspnea, cough, fatigue, esophagitis, or rash, but no grade 3. For us, we've gone back and looked at our data. We're working on a publication summarizing our SMPC process and findings. Mostly the examples some of the examples that have popped up have been a little surprising. So carotid blowout, for example, can happen with patients with re-irradiation. That's not a structure that appeared on our matrix at all. And typically just isn't part of what physicians are looking at. But as we recognize that we're still, you're seeing in that 1% range of incidence, so it's still small like it was with the lung. You're saying it's small, but what are the things that show up? Things like that do. So I think all of this reveals some gaps that I think would be good for multiple institutions to work together to address. Standardizing, providing DICOM-RT data from outside to the currently treated institution, it just happens so often that it's hard to get that DICOM-RT. And we've learned as we do this process that our estimations for how much dose can be safely delivered allow us to give more dose if we're using the DICOM-RT than if we're just using the point dose calculation. So if I don't have DICOM-RT and I have to make a worst dose, a worst case estimate, it's going to mean that I'm estimating that they get a higher dose to those structures than I would have got if I had used the DICOM-RTs, which means we're undercovering the target because we don't have that information to inform the decision. We're forced to deal with insufficient information. So just making it easier to standardize how people get this information would be a big benefit for patients, because then you get, the physicians will be able to put in more dose to control the disease. From these, articles, our own experience, I'll be interested in your experience. We know that the incidence of toxicities are really small, which means nobody has a whole lot of data. And it underscores the value if we could be standardizing data collection by multiple institutions, then we could get toward using the combined experience to define practice guideline recommendations. So instead of a matrix that defines EQD2 limits and particular timeframes based on the best experience at a particular institution, they could actually evolve from multi-institutional experience to set those guidelines. It's just, there's just not enough information right now to be able to do that really well. And I think if we could be combining, it would be a lot better. The treatment planning tools could be better. They were designed to let you treat this patient. They are absolutely awesome for that. As we saw from our ramp up in publications, the advent of re-irradiation becoming a big part of our practices has only been in the last few years. And so I think appreciation for what we need in those tools is evolving, but it would be much better. I showed you those displays of the physical dose. It'd be much better if those were biologically, EQD2 dose distributions, where I could include the time-dependent discounts. Be much, it could give much more information to the physicians about that. And likewise, when we're asking how much dose is left to give, then if we could, with plan sums, sometimes you may have used subtraction in plan sums to figure out how much is left. And if we could be doing that with biologically corrected dose distributions, then we could be spatially specific. So remember, in my point dose calculation, my problem is I can't tell you where the point is that you have to be worried about. But if we could be doing that sort of subtraction with a biological dose display, then we could say, it's right over here. Over there, you don't have to worry so much. And as patients move between institutions, and they need to absorb the reports of other institutions for what they did, I think standardizing reporting approaches so you can share that detail, so that when you get something from our patients or we get something from your patients, they come and they get treated, there's enough information there that people can understand what they should take as their next best step. Thank you.